which is by Dr. Wilfried Mullens from Belgium, on how to treat congestion in heart failure. Till they put him live, I'm just going to entertain you. This is a big contentious issue, how to treat congestion. Because actually, you treat congestion by a lot of things, but mainly by diuretics, okay? And we're going to see now. And diuretics are not produced by any big pharma, so nobody will talk about them. People will tell you about the 4 new drugs and the 4 new classes and all sorts of things. But if you get the patient in acute heart failure, and you take them into the hospital, hospitalized, you're not talking about the 4 big ones, okay? You're talking about decongesting that patient so that that patient does not die in hospital. And then you're going to start the evidence-based therapy, which is going to hopefully reduce the mortality and reduce subsequent hospitalization of that patient. But it's extremely important that people don't think that they can just take a pulmonary edema patient and start giving him ARNI or SGL2 inhibitors and thinking that they're going to get away with this. We actually, the majority of us, don't know how to use diuretics properly. We don't know how to calculate the dose. We don't know how to work out the fluid balance. And we don't know how to work it in relationship to the kidney function. And we don't know what to monitor. So if you start giving a patient diuretics, do you give them a drip? Do you give them pills? Do you give them boluses? And what do you do the next day? If your patient got 4 liters of urine out, or 2 liters of urine out, or no urine. And are there machines that you can use to remove this extra fluid? We'll see. We're really looking forward to hear this presentation on how to treat congestion in heart failure, which actually can be quite life-saving, by Dr. Wilfried Mullens from Belgium. I think we're starting now. Dr. Mullens, thank you. Thank you for being with us. I'm Hani Raghi from Cairo.
Okay,
and
good morning, everybody.
To a room full of cardiologists, but with all the precautions in order not to get COVID, plus hundreds of virtual attendees. Please, go ahead.
Okay, well, thank you for the invitation to give this talk also on behalf of the European Heart Failure Association. It's really an honor and pleasure for me to present the topic about congestion and heart failure. So I am a heart failure specialist. I like to have a physiological approach, and I'll try to explain in the upcoming 20 minutes how I think you can decongest a patient through a better implementation of diuretic therapy. I think, first of all, one of the most important points is that we often underappreciate the risk that our patients have to die or to be hospitalized with heart failure. In the recent DEPA trial, it was up to 21% risk at 1.5 years. That means that one out of 5 of the patients that you see in the outpatient department will either be dead or hospitalized within 1.5 years. And that's not such a good prognosis. That prognosis is even worse if your patient is recently hospitalized, because it goes up to 60% at 1 year, and especially if you send your patient home with ongoing congestion. Therefore, congestion is a main therapeutic target if you see a patient with heart failure. Congestion arises in the kidney, and the kidney gets a tremendous amount of blood, almost 1 liter of blood every minute. That means that hemodynamics in the kidney are very important to understand. We and other research groups showed already a decade ago that the kidney is extremely sensitive to increased central venous pressure. As soon as you increase the central venous pressure, the kidney will start to retain more sodium. And that happens very early on. We did an animal experiment a couple of years ago in which we did a partial ligation of the vena cava inferior in rats. These rats did not have heart failure, but we only induced very mild increases in central venous pressure in the abdomen. And already after a couple of weeks, we saw irreversible morphological changes to the kidney. That means, again, that the kidney is very sensitive to increases in congestion. That's also a reason why we're paying more attention with imaging to the kidney flow. Above the horizontal line is the arterial flow, and below the horizontal line is the renal venous flow. And normally the venous flow should be continuous. That means that constantly blood is leaving the kidney. As soon as you have a very mild increase in central venous pressure, that continuous signal becomes discontinuous, and that is exactly the moment where your diuretic therapy is less effective. So putting your echo probe instead of on the heart but on the kidney will give you more information about diuretic response and about congestion in the kidney. And then what is the problem? Here I forced one of my heart failure caregivers to eat a tablespoon of sodium. And as you could see, it's actually disgusting. Yet we have an unnatural craving for sodium, but we fail to understand that our bodies have difficulties in getting rid of sodium. The reason is that we absorb every bit of sodium that we eat. That is because we have a highly developed RAS system. Our RAS system is very high because it really wants to retain every bit of sodium that we can have our hands on. And then if you eat sodium, the sodium will be filtered in the kidney. A normal kidney filters about 180 liters of water and sodium every day. And we filter about 1 kilogram of sodium in the kidney daily. If you have a very poor GFR, let's say 10 mLs per minute, you still filter about 150 grams of sodium per day in your kidney. If you eat about 4 grams of sodium daily, that still means that you filter enough for your body to excrete the part that you have eaten. So the filter in the kidney is not the problem, but it's the reabsorption of sodium. You filter the sodium and then you reabsorb the sodium. What most people fail to understand is that we reabsorb most of the sodium what we filtered in the proximal parts of the kidney. That means in the proximal tubules. Up to 85% of the filtered sodium will be reabsorbed in the proximal parts of the kidney. Bear in mind that the loop diuretic therapy that we are using works distal from the proximal parts of the kidney. Therefore, it will be less effective if you filter less, and especially if you reabsorb more in the proximal parts of the kidney. That's one of the reasons why you have to understand how you can use diuretic therapy more effectively to decongest patients. Eventually, if you don't excrete enough sodium, you're going to have an increase in plasma volume, and therefore you're going to be admitted with signs of congestion of heart failure. This is the only prospective randomized double-blind controlled trial with loop diuretic therapy in heart failure. It's called the DOSE trial. It's been reported more than a decade ago in about 300 patients done in the US. And in that trial, 4 different strategies were compared. A low-dose diuretic versus a high dose, continuous versus bolus infusion. So 4 different treatment strategies. What you could see is the end result. And after 2 months of follow-up, half of the patients were either dead or hospitalized again. There was no difference amongst the 4 different treatment strategies. So again, that means that half of the population which was randomized in this randomized controlled trial was either dead or re-hospitalized. If you look at the secondary endpoint, which was freedom from congestion, only 15%, that means 1 out of 6 of the patients who entered the trial was actually dry at the end of the decongestive phase. That means that physicians did not do a good job, or that the strategy used in the trial was not effective enough to decongest the patient. Of course, there are many reasons to explain the bad results of the DOSE trial, but we are facing the problem that a normal heart failure patient who is already on a loop diuretic doesn't have a normal diuretic response. Because if you would infuse yourself, if you don't have heart failure, with 40 milligrams of furosemide, you should be out about 3 liters of water and sodium. Almost none of our heart failure patients are actually doing that. That is the reason why, together with HFA, we took up this daunting task to write a position paper about how to use diuretic therapy in heart failure. And it took us a while before we came to this final position paper, but it holds a wealth of information. So this is a very simple algorithm. If you're faced with a patient with congestion and volume overload, the first thing you do is you ask your patient, do you already take a loop diuretic? If the answer is yes, I already take a loop diuretic, then you give him twice the amount of loop diuretic IV bolus as soon as you see the patient. So that means if your patient was on 40 milligrams of furosemide and he enters the emergency room, you give him immediately 80 milligrams of furosemide IV bolus. There is no time to waste here. You shouldn't wait hours and hours before you give the drug. Give it as soon as you see the patient. If the patient's loop diuretic naive, meaning he's not on a loop diuretic yet, you give him 40 milligrams of furosemide IV bolus. 40 milligrams of furosemide equals 1 milligram of bumetanide. There are more and more data emerging that the sooner you give the drug, the higher the likelihood will be that that patient will be dry at the end of the treatment period. Then the next step is to evaluate the effect of the loop diuretic. And you have to compare it with doing a PCI in a STEMI patient. You evaluate the effect of the therapy. The same is true for diuretic therapy. You have to evaluate the effect of the diuretic therapy within the first hours after the administration of the drug. Because loop diuretics work for 6 hours. They don't work for 24 hours. And we give you two options to evaluate the effect of the drug. Either you take the difficult way, and that is measuring urinary output. I say the difficult way because it's not easy to measure urinary output because patients pee everywhere, but not in the container that you give them. But if you would measure urinary output, it should be at least 100 mLs per hour. A more easier way is to measure sodium content. And you take the first sample, so the patient empties his bladder, you give the IV loop diuretic, and the first urine he produces will be sent to the lab. And you measure the sodium content. That should be at least 50 mg per liter. And then you reassess congestion. So after 6 hours, when you gave him the first dose of loop diuretic, and you interpret the results of the effect, you give the second dose. So if your patient didn't respond well, meaning he had less than 50 mg per liter sodium or less than 100 cc's per hour urinary output, you double the dose of the loop diuretic. So if you gave him 80 milligrams previously, now you give him 160 milligrams IV bolus. If your patient, however, is responding well to the therapy, you just continue your current regimen twice daily. You do standard non-invasive monitoring of heart rate. You shouldn't put in catheters if not necessary. You continue guideline-directed medical therapy. You consider early use of MRAs. And we still advocate salt and water restriction during acute heart failure phases. Why do we emphasize so much on urinary sodium content? Because there are more data showing that is important to titrate diuretic therapy. This is one of the many data. When you give consecutive days of loop diuretic therapy, you could see on the left-hand panel, you have the same amount of urinary output per milligram of bumetanide. However, the quality of the urine is decreasing rapidly. During consecutive days, you see less sodium appearing in the urine, and we still feel that sodium is the culprit that we need to target. What do you do the next day? So the next day, the morning after, you again evaluate congestion, and you evaluate 24 urinary output. If your urinary output is more than 3 to 4 liters per minute, per day, and you still have persistent congestion, you continue recurrent dose regimen. If you didn't reach your target, again, you're going to double the loop diuretic until you reach the threshold of 200 milligrams of furosemide bolus. 200 milligrams furosemide bolus is enough. There is no need to give more because it's not going to give you additional benefit. If you reach the 200 milligrams of furosemide, you should add another diuretic agent. What are the options? The first option might be a thiazide. Bear in mind that thiazides work very distal in the nephron. They don't work proximal, but they might counterbalance the distal hypertrophy that we often see with chronic utilization of high-dose loop diuretic therapy. The advantage is that they also work in low GFR states, but the disadvantage is that they have a slow GI absorption, and therefore you better give them hours before you give the loop diuretic therapy, which makes it a little bit impractical to use, because you should be giving a thiazide hours before you've given the loop diuretic. Bear in mind that they are linked with a higher mortality even after extensive propensity matching. That means that if you give a thiazide during the acute phase of heart failure to decongest your patient, that is a drug you should stop once your patient is dry, because in the long run, they're linked to more iron disturbances, and that is linked to higher adverse outcomes. What is the other drug you might think of? Well, that's high-dose spironolactone. This has been tested in the TINA trial, where they were comparing 100 milligrams of Spiro with 25 milligrams. Unfortunately, it did not lead to more diuresis, and it also did not lead to a more reduction in NT-proBNP. So while spironolactone is a very important drug as a disease-modifying agent, it does not really help you to decongest your patient. And then there are the promising agents, the agents that work in the proximal parts of the kidney, because the proximal part of the kidney is the target, because there is the place where you absorb most of the sodium. The oldest drug we have is acetazolamide. You can give it 500 milligrams IV bolus once daily on top of loop diuretics, and it actually boosts the loop diuretic effectiveness. We're doing in Belgium a double-blind randomized trial to compare acetazolamide plus high-dose loop diuretics versus acetazolamide versus placebo plus high-dose loop diuretics, and we hope to finalize the trial by the end of the year. If this trial would be beneficial, then we would have really a very important new compound that we can use worldwide, because the drug only costs €8. So it's really worth giving it a try already now. The other agent is, of course, the SGLT2 inhibitors. SGLT2 inhibitors block glucose uptake in the proximal parts of the kidney and also help to increase urinary output. They probably don't lead to an increased natriuresis in the acute phase, but they do increase diuresis acutely. And therefore, they might be used as a smart osmotic diuretic agent. Let me explain it a little bit. If you give classical decongestive therapy, you reduce the hydrostatic pressure in the plasma, therefore you recruit volume from the interstitium. If you give an SGLT2 on top of loop diuretics, you also increase the oncotic pressure in the plasma, therefore you're going to boost the reabsorption of water from the interstitium back into the plasma. That is the reason why we think they might be used to help you decongest your interstitium more effectively than only with loop diuretic therapy. We're actually testing this HFA algorithm in a prospective randomized observational trial worldwide, and all continents are participating. If any of the sites that are actually watching now would like to participate in the observational trial, just send me an email and we try to get you on board as well. Now, the second point I would like to make is a little bit emphasize the kidney function through the decongestive phase, because often we're faced with worsening renal function during decongestive therapy, meaning you see an increase in serum creatinine and a reduction in GFR while you're administering decongestive therapy. The first thing you have to do there is to assess again the diuretic response. If your response is well and the GFR drops, that's not a bad thing, and you should just continue your decongestive strategy. We call that now pseudo-worsening renal function. That's not really something to worry about. However, if you have a poor diuretic response in the face of ongoing congestion, then you have to assess if there is hyperperfusion. So if you have congestion and a poor diuretic response and worsening renal function, you assess if there is hyperperfusion. Hyperperfusion does not happen often. It's less than 1% of the patients, and those patients need inotropic support. However, 99% of the patients do not have hyperperfusion. They are not in cardiogenic shock, and they don't need an inotrope, because if you give them an inotrope, their prognosis will be worse. What they might need is an addition of a vasodilator. Why? Because a normal heart is preload dependent. That means if you increase preload, stroke volume goes up. If you give a vasodilator to a normal heart, you're going to reduce blood pressure because you reduce the preload. However, if you have a failing heart failure patient, especially HFrEF patients, they are afterload dependent. And if you give a vasodilator to a patient with failing HFrEF ventricles, you're going to reduce the afterload, therefore increase stroke volume, and you're going to put them on a better point on a Frank-Starling curve, therefore increasing stroke volume also from the preload perspective. So vasodilators actually work in patients with decompensated heart failure, and they might help you to decongest your patients better. We often use nitroprusside, but there are other drugs which are equally effective. But nitroprusside is a drug that is shown to be safe if you use it well, and it can help you to decongest your patients more effectively. What do you do after you decongested the patient? What do you do with your loop diuretic therapy? Well, it's important to realize that loop diuretics should be used dynamically. They're not a one-size-fits-all dosing, and you should also not continue a high dose if the patient doesn't need it. Because if you give an inappropriately high dose on the long run, that will hamper the uptake of the disease-modifying agents because it gives you more hypotension. So they often need a loop diuretic on the long run, but you should try to lower down the dose as much as possible. What you instead should do is try to increase the disease-modifying agents. The ACE, the RNEs, the beta blockers, the MRAs, those are the drugs that you should increase, and you should increase the implementation of those drugs through a multidisciplinary disease management program. Then, of course, we have 3 new life-saving compounds which can be used in ambulatory heart failure patients with ongoing congestion. It's sacubitril valsartan, DAPA, and empagliflozin. Bear in mind, again, the very high event rates in the comparator group. It was up to 26% at 2 years in Paradigm. So these patients who are ambulatory have a very high risk for adverse outcomes, and it's worth adding these drugs to those patients if they fulfill the inclusion criteria of the trials. These drugs are extremely effective also on the kidney function because they lower down the progression of CKD. Both ARNI therapy and SGLT2 have shown to decrease the GFR deterioration. And GFR is a more important prognosticator than ejection fraction in our heart failure patients. This is another graph. When you are normal, you lose about 1 ml of GFR every year once you reach the age of 50. If you have heart failure, that goes up to 2.5 mLs per year, and if you have heart failure with uncontrolled diabetes, it goes up to 5 mLs per year. Therefore, reducing the reduction in GFR with utilization of ARNI or SGLT2 is of utmost importance. When you look at GFR, we all know that if you have a low GFR, that your risk is really high for adverse outcomes. However, you have to do the interpretation of GFR on the background medical therapy, because you can have a GFR of 50 without an SGLT2 and without ARNI therapy, or you can have a GFR of 40 with SGLT2 and with ARNI therapy, and then I prefer the GFR which is lower with good background medical therapy. So don't only look at GFR, but look at the entire status of the patient, including the medical therapy. Then, of course, the question is, which drug should you use? Should you use only one drug, or should you combine all the 4 different agents in HFrEF, which we know that are life-saving? Of course, the trials have been done in a consecutive manner, so it's very difficult to answer that question based on the trial data. However, there are more observational data demonstrating that it's better to give a little bit of all than all of one drug. So it's better to combine the drugs in the lower dose than only give one drug in the maximum dose. The other question is, do patients still need an SGLT2 if I already gave them ARNI therapy? The answer is most definitely yes, If your patient is on ARNI, beta blocker, and MRA, and still has signs of congestion based on an elevated NT-proBNP, for example, there is still benefit of adding an SGLT2 inhibitor. That is the reason why HFA wrote down that DAPA or AMPA are recommended to reduce the combined risk of heart failure hospitalization and CV death in patients with heart failure and reduced ejection fraction, independent of their diabetic status. So to conclude, ladies and gentlemen, diuretic therapy in congestive heart failure patients, it's early treatment and also early evaluation of the diuretic effect. After 2 hours, you can either use a urinary spot sodium analysis or measure urinary output. You have to reassess the ongoing need for diuretic therapy after 6 hours, and if needed, change the dosing. But chronic prevention of congestion does not come through diuretic therapy, but it comes through up-titration of neurohormonal blockers, treatment of comorbidities, and inclusion in a multidisciplinary disease management program. With regards to kidney disease, CKD affects more than half of our patients. Important to recognize it is a doubling of risk for all-cause mortality, so it's a more stronger predictor for outcomes than ejection fraction. But we often misinterpreted GFR changes, which results in inappropriate discontinuation of decongestive or neurohormonal blocker therapy. Thank you for your attention, and I'm more than willing to answer any questions that you still have.
Very much, Dr. Mullens. This was amazing. Just for the info of attendees, Dr. Mullens is the president of the Heart Failure Association of Belgium, his country, and is also a prominent board member of heart failure councils on both sides of the Atlantic, European heart failure and the American heart failure. And as you just saw, he's the lead author of most of the new position statements of European Society of Cardiology in heart failure. And I think this presentation should be obligatory material to everybody who's working in an intensive care unit and who is diuresing acute heart failure patients. And you have to remember and remind our fellows that inotropes are going to make our patients worse. We saw the floor is open for discussion and questions. The first question, Dr. Mohammed Salim.
Thank you, Professor Mullens, for this excellent presentation. You know that patients came with acute decompensated heart failure, and then we will give them diuretics, and after a while they became dry. After this point of time, some patients we cannot discontinue diuretics, and some of them we can discontinue and adding new neurohumoral blockade for better outcome and decrease hospitalization and mortality. In which category of patients like RV dysfunction, tricuspid regurg, and some other patients we cannot discontinue diuretics. What do you think about this category of patients in which we cannot discontinue diuretic therapy?
I think that's the most difficult question. I think everybody is puzzled with that question. I think I absolutely agree. The patients that we also are not able to lower down or stop diuretic therapy are the ones with RV dysfunction. And they often need diuretic therapy to keep them dry. And they, of course, have a higher risk for recurrence of heart failure decompensation. But I still feel it's important that we do a better job during the hospitalization to decongest those patients. Because often if you decongest a patient with RV dysfunction more thoroughly, their RV function improves, their TR is reduced, and then you can still lower down the diuretic therapy. So I think you're absolutely right. If they keep on having poor RV dysfunction with significant TR, they often still need diuretic therapy in the long run. But a lot of our patients can go without if we do a better job in the initial phase of decongestion.
Thank you. That was an excellent. We have two more questions, but I'll ask one since I'm here. After discharge of patients, how do you monitor them at home? In Egypt, we don't have remote invasive pulmonary artery pressure like we read in. Is monitoring at home by symptoms and weight enough? Is there an algorithm that you can quickly tell us?
Well, if we, of course, we don't have invasive hemodynamic monitoring all of our patients. Only very rarely we place these very expensive devices like MEMS technology. I think it's important to follow the guidelines, and that means if you have a patient with acute heart failure admitted, that you see him back within the first couple of weeks to reassess his congestion status. And often, if that patient is dry, and you then start already to increase the neurohormonal blocker therapy, it goes well. Again, I think if you do the job well during the hospitalization and you see him back early after the discharge and you then start to implement the disease modifying agents, it often goes well. And then, of course, we use the same algorithms like you do. We ask them to monitor their weight. We ask them to monitor their blood pressure. But by just looking at them, paying more closely attention to them, I think we can avoid a lot of problems.
Thank you. Dr. Leo, yes, we have two questions. Yeah. Professor Naamani?
Professor Mullens, many thanks for the very elegant and comprehensive presentation. In the era of the four pillars or fantastic four drugs for HFrEF patients, especially with the favorable effect of SGLT2 inhibitors on HFrEF patients, especially with renal impairment, do we have any available evidence or data that one type of diuretics is preferable over the others in conjunction with SGLT2 inhibitors, especially in renal impairment patients?
I don't think we have the data currently available. So we don't know it yet. And again, I think I would rather put everybody on an SGLT2 inhibitor if they have HFrEF currently and ongoing congestion during the hospitalization, because we know they're very safe to use, they're easy to use, and I would reserve the loop diuretic therapy more as a dynamic therapy. So I think we have to change the way we're thinking. An SGLT2 inhibitor will be like baseline therapy, and the loop diuretic will be like will be a dynamic therapy that we need better tools in the long run to monitor the need for loop diuretic therapy. It's like the previous question, what we're doing now, but it's still too early to say much about it, but we're trying to measure sodium content also in an ambulatory phase to predict the ongoing need for loop diuretic therapy. But more specifically, if you ask me, is bumetanide or furosemide better if you combine it with SGLT2? I don't think so. It's probably more a class effect of the loop diuretics.
Dr. Leo?
Professor Mullens, thank you very much for a wonderful talk and overview of the diuretics. It's a quick question for you. In your vast experience with wet patients in the ICU, would you prefer to put them, according to the dose trial, would you prefer to put them on intravenous continuous infusion of diuretics, or would you use the pulse doses, and in which patient would you use this or that?
Yeah, so in the algorithm, we put forward bolus and not continuous. And the reason for that is double. First of all, bolus is more easier than continuous infusion because you can also use bolus on a normal ward. And the bolus also allows you a little bit better to change the dosing, because if you look at the scheme where you actually assess the effect of the drug after a couple of hours, you can easily change the dose. The second point I would like to make, probably continuous infusion is equally well on one condition, that you give high enough dosages to start, because loop diuretics need to be actively secreted by the blood running into the kidney, into the tubules. So if you start a continuous infusion, you always have to give first an IV bolus of, for example, 80 or 100 milligrams of furosemide before the drug can actually work. So for ease of use, we prefer bolus, but it doesn't matter that much what you're doing as long as you decongest your patient and as long as you assess the effect of the loop diuretic. So if you use a continuous infusion, you still have to assess the effect of the diuretic after a couple of hours and change the dosing accordingly.
Professor Zawawi from Alexandria University.
Thank you, Professor Mullens. You mentioned that incomplete decongestion before hospital discharge is a poor prognostic predictor of recurrent hospitalization and so increase mortality. Do we need, before discharge, to measure N-terminal pro-BNP or to measure the inferior vena cava diameter? Do we need lung ultrasound before discharge to be sure that tissue decongestion This is the first question. The second question, what are the rules of aquaretic, the vasopressin receptor inhibitors? Think.
Yeah. So the first question is very important. I think we indeed have to assess the patient for ongoing congestion before we discharge him. And in that document, but I didn't show it, we give you a lot of clinical and technical evaluations that you can use. Of course, we all know that if NT-proBNP goes from 8,000 to 4,000, that is a better situation, and it goes from 8,000 to 10,000 on discharge. But we don't routinely measure NT-proBNP at discharge because of cost and also because it's more correlation. But we do a good clinical examination, and we also do an echocardiogram, a very quick look echocardiogram to assess if there's still ongoing congestion. The second question about aquaretics, I don't think they have much role to play currently unless your patient has dilutional hyponatremia. In that setting, they might be important drugs. But bear in mind that all the trials which have been done with the aquaretics were not really positive on the long run. They're also very expensive drugs. Even in Belgium, they cost more than €1,000 per vial. So we hardly use them because they don't give you natriuresis.
Thank you. I'm going to ask a very last quick question because we have to move on. Is there any role for low-dose dopamine in what's called the renal dose? Because this is very common in Egypt, and you can even say yes or no.
No, I don't think we have any data to support it. I mean, I know a lot of people use it, but I was also on the algorithm. I don't think you should use it if there's no need of hyperperfusion.
Thank you very much. Your presentation will probably save some lives. Thank you.
Okay,
Thank you.
Thank you. Pleasure.
Bye-bye. Thank you.
Bye.